This short video will discuss the purposes of IV fluid and electrolyte replacement. We do this when the oral intake is not adequate or that we have losses that have occurred or are ongoing and we need to replace them. And types of fluids are going to be categorized by their tonicity. So we use, to correct mild fluid and electrolyte deficits, we use a combination of water, glucose, potassium, and sodium. So hypotonic solutions have a lower osmolality when compared with the plasma, and what they do is dilute the extracellular fluid. So the water moves from the extracellular fluid to the intracellular fluid by osmosis. So this is a good maintenance fluid. It's used to treat hypernatremia. You need to monitor for changes in mentation. D5 in water is technically isotonic because the dextrose is metabolized and you just have water left over, free water. And so it provides some calorie, only 170 per liter. It's used to replace water losses and helps prevent ketosis. Isotonic fluids are going to be similar osmolality as to the extracellular fluid. They expand in extracellular fluid only. There's no net loss or gain from intracellular fluid, and these are ideal to replace extracellular fluid volume deficits. This is going to be your go-to fluid. If someone has a low blood pressure and you want to give them a fluid bolus, you'll give them normal saline. Or if you wanted to correct a low blood pressure or give them some fluids if they're deficit. So normal saline and Ringer's lactate would be the choices to use. So normal saline is isotonic. It has slightly more sodium chloride than the extracellular fluid, and it's used for both fluid replacement and sodium replacement. And this is the only fluid used whenever you're giving a blood transfusion. So when you're giving a blood transfusion, you're going to get like 250 cc's of normal saline and hang that, and then hang your blood. Lactated Ringer's solution, it is also isotonic. The difference is that it contains sodium, potassium, chloride, and calcium and lactate. And this is contraindicated then for people that have liver problems, that have people that have high potassium, or if they're very severely hypovolemic. So you want to be careful with patients that are in renal failure that already have a high potassium level. You don't want to give them Ringer's lactate. A lot of times in surgery, though, anesthesiologists love to use lactated Ringers. So you'll see these patients coming back from OR with lactated Ringers running. So the IV fluids, if they're hypertonic, they have a higher osmolality compared with plasma. So hypertonic is going to draw water out of the cells into the extracellular fluid. This requires you to monitor your patient with blood pressure, lung sounds, and serum sodium levels. D5.5 is also hypertonic. It's a common fluid that's going to give IV maintenance fluid to replace fluid loss, and a lot of times potassium is added for maintenance or replacement. D10 in water is hypertonic, and it provides a little bit more calories than just regular D5 in water. It provides free water but no electrolytes. And this is a solution that you're going to have on hand if you have a patient on total parenteral nutrition. And if they say the bag runs dry because pharmacy hasn't mixed your next bag, TPN has a very high solution of dextrose. TPN is 50% dextrose, so you don't want to just, if your bag runs out, you just don't want to hang anything or nothing, because your patient will get a low blood sugar. So in place of the new bag of TPN that's not ready, you would hang D10 at the same rate to prevent your patient from getting hypoglycemic until you get your next bag of TPN. Colloids are examples of that are fresh flows in plasma or albumin, or there's some they're human products, human plasma products, or there's some synthetic products available called dextran or hespan, and these are going to be volume expanders that are going to stay in the vascular space and increase the oncotic pressure. So these colloids are going to affect blood coagulation by interfering with the coagulation factor 7. So we'll move on, talk about central venous access devices. We're going to have an opportunity to look at them and play with them on our mannequins in the skills lab during clinical before we go to the hospital. So these catheters are placed in large blood vessels, usually the subclavian vein, the jugular vein, or the main top types are going to be centrally inserted catheters or peripherally inserted catheters. So the peripherally inserted central catheters are sometimes referred to as PICC, P-I-C-C. And also a third type of centrally inserted catheter is going to be an implanted port, which you will see if you go to the Lucy Kersey Center or the Cancer Center during clinical. So these lines are going to permit frequent, continuous, rapid, or intermittent administration of fluid or medication. And it allows us to safely administer drugs that could be very potential vesicants. And they can be used to administer blood products or parenteral nutrition. These devices are going to be useful for patients that have to have a long-term vascular access, someone that needs to be on antibiotics for a long time if they have osteomyelitis or if they have endocarditis. We can also use these devices for hemodynamic monitoring. We can get blood samples, venous blood samples from them. And we can also use them to inject radiopeg contrast dye if they're going to go to the CAT scan for a scan with contrast. So this is a picture of a tunneled central venous catheter. The tip of the catheter is going to be in the superior vena cava. And this tunneled catheter is something that a surgeon would put in surgery. It's not done at the bedside. The advantages of central lines: we can use them right away. We can reduce the repeated venipunctures that someone in the hospital has to endure, and we can decrease the risk of extravasation. Some of the medications that we give patients are very dangerous. They increase the risk of extravasation, and sometimes the patients have to have skin grafts or even amputations because the drugs are so dangerous when they extravasate. So the disadvantages: they would increase the risk of systemic infection. It's an invasive procedure. They're inserted into a vein in the chest or the abdominal wall with the tip resting in the distal end of the superior vena cava. And they could be tunneled or non-tunneled. And if they are tunneled with a Dacron cuff, that anchors them and it decreases the risk of infection. This is a picture of a peripherally inserted central line catheter, and it can be inserted in the basilic or cephalic vein. It can either be a single lumen, a double lumen, or a triple lumen. And you will see these quite frequently in the hospital. So the tip inserted here, and the tip is going to go into the superior vena cava. Sometimes the catheter is inserted peripherally like this, and they can't get it all the way up to the tip of the superior vena cava, and it stops somewhere around here, and they call those a midline catheter. So other examples of long-term catheters include a Hickman, a Brovac, or Groshon. So a single lumen non-tunneled catheter is good for patients who need access like for 1 week even to 6 months. You cannot use that arm for blood pressures or blood draws once a patient has a central line in whatever arm it is. The advantages include that there's a lower infection rate, there's fewer insertion-related complications, it decreased the costs for the patient, but there are complications of deep vein thrombosis and phlebitis. So when I talk about the midline catheters, meaning instead of this whole length going all the way up into the tip of the superior vena cava, a midline catheter is going to be like 3 to 8 inches long. And it could either be a single lumen or double lumen. The care is similar to a PICC line, and these midline catheters can stay in place up to 4 weeks. This is a picture from your textbook that shows a cross-section of an implantable port, and the kind of needle that they use is a Huber point needle. You can see it looks like a J, and it has a deflected point on the end of it that prevents coring onto the part of the port septum. And so the Huber point needles are used to enter the implanted port, and it's a 90-degree angle for the top entry of the port. And then the port has a titanium or plastic self-sealing silicone septum. So sometimes drugs are placed in the reservoir of the port through the skin by a direct injection or through injection into the established IV line. So again, these ports are going to be good for long-term therapy. There's lower risk of infection, and there's cosmetic discretion. So a patient, if they're not being infused, no one would ever know that they have the port in place. So some of the complications for all of these central lines could be catheter occlusion, embolism, infection, pneumothorax, and catheter migration. So a catheter occlusion could be from a clamped or kinked catheter. The tip could be against the wall of the vessel. There could be a thrombosis or a buildup of precipitate in the lumen. An embolism could be caused from the catheter breaking or a dislodgement of a thrombus or air entering the circulation. An infection could be contamination during insertion or during use, or migration of organisms along the catheter, or if a patient is immunocompromised to begin with. Pneumothorax can occur when there's perforation of the visceral pleural. When that happens, the patient's going to be in immediate respiratory distress, and they would need an insertion of a chest tube. Catheter migration is another complication, and it could be due to improper suturing, trauma, forceful flushing, or just sometimes they can just happen spontaneously. So what can you do to maintain the patency of the PICC line? Well, first of all, you want to flush according to the institutional policy. And usually that policy says that you flush with at least 10 cc's of normal saline after every 4 to 8 hours and after every use. And you use a pulsatile flush technique and appropriate clamping depending on the type of pressure cap used. If there's a positive pressure cap, you can remove the syringe before clamping. If it's a negative or neutral pressure cap, clamp the syringe while maintaining positive pressure while you instill the last milliliters of saline. So you want to make sure that you're teaching the following. Make sure that there's proper technique of cleansing the port prior to access. Be sure that you flush it properly. Know how to administer an antibiotic. So you're going to flush with saline, administer the antibiotic, and then flush with saline again. Always be on the alert for any signs and symptoms of occlusion and infection, and monitor. You need to know who to call if you have a symptom of occlusion or infection. Sometimes if you're checking and you don't get a blood return, and the previous shift got a blood return when they flushed their central line, then you could call the physician and get an order for TPA to instill that and open up the catheter. So it's important to clamp the catheter and keep the cap on the connection secure. Otherwise, the patient could get an air embolism or they could exsanguinate. So you want to make sure that you change the injection caps, and we're going to learn this as we move through the semester on how to change a central line dressing, whether it's a PICC line or a triple lumen catheter. And the policies will review on how often to change the tubing, change the injection caps, and change the dressing itself. So you want to make sure that you use a 10 milliliter syringe or larger. If you use a smaller syringe, you're going to increase the pressure and it's going to damage your catheter. And you want to use a push-pause technique. So always inspect the catheter and the insertion site, assess to see if there's any pain. Usually dressings are changed once a week unless they're soiled, and you would use a transparent dressing. If you have a gauze dressing, you would need to change it daily. So how would you remove a PICC line? Well, you want to put on the pair of non-sterile gloves and remove the dressing. Then you put on sterile gloves, put on a mask, have the patient put on a mask, turn their head to the side, remove the sutures, and then slowly and steadily withdraw the catheter. If you meet resistance, you stop. If resistance is met, you could apply warm compresses for 20 minutes and retry. If you still have resistance, you need to notify the healthcare provider. Have the patient perform the Valsalva maneuver as the last 5 to 10 centimeters of the catheter is withdrawn. You want to immediately apply pressure to the site with a dry sterile dressing to prevent air from entering and to control the bleeding. You want to inspect the catheter tip to determine that the entire catheter is there. After bleeding is stopped, you apply an ointment and a sterile dressing. Usually the policies include putting in a sterile Vaseline gauze dressing over the site and keep it there for 24 hours. So removing the central venous access devices, you do according to the policy of the hospital and following your scope of practice. This is an algorithm that shows nutritional support algorithm. So we always want to use the gut if at all possible. So if a patient's not able to eat orally, we want to put in a PEG tube, a nasogastric tube for feedings. But if we can't use the gut, then we have to go for enteral nutrition. So parenteral nutrition, what they are is they're solutions that as a base they contain dextrose and protein. The protein is in the form of amino acids, and a 3-in-1 or total nutrient admixture. It can include, it could be bagged all together. You would have fat emulsion, dextrose, and amino acids, or they could give them separate. There could be the fat emulsion, which is also called intralipids, in one container, and then the TPN solution would be in a second IV bag. So the solution for the TPN would be 50% dextrose, and with the amino acids, and then they also add multiple vitamins, trace elements, and sometimes, depending on the patient, they could add regular insulin. So this is indicated for someone that has chronic severe vomiting and diarrhea, if they have complicated surgery or trauma, if they have a GI obstruction, if they have any GI tract abnormalities or fistulas, intractable diarrhea, severe anorexia nervosa, severe malabsorption, or short bowel syndrome. You always want to try to use the GI tract if possible, because even if you give someone a tube feeding with just a trophic rate, giving someone tube feeding through their GI tract even at 10 cc's an hour is going to maintain their normal GI floral, which is going to be helpful for them. So parenteral nutrition, it's going to be important to monitor the patient's lab work, the electrolytes, and the pharmacist is going to be monitoring that and usually making the changes to the additives for the parenteral nutrition. So nurse's job, then, make sure you're checking vitals every 4 hours, doing daily weights, checking glucose every 4 to 6 hours. Sometimes the patient's getting a concentrated solution, dextrose 50. So if a patient's a diabetic, they may need some extra insulin. So these patients are be on the glucose checks, and some of them might be ordered regular insulin coverage depending on what it shows. You need to use an infusion pump and make sure it's infusing properly. So the electrolytes, the BUN, the CBC, liver enzymes are all going to be important lab works to monitor. You need to make sure that you're observing the dressing, to make sure that you're using proper techniques so that you don't give your patient an infection. And monitor for refeeding syndrome. So before you hang a bag of parenteral nutrition, you want to check the label and check the ingredients so that what's in the bag is what the doctor ordered. You want to examine the bag for any signs of contamination. It's discontinued after 24 hours. You change the tubing after 24 hours. And when you hang a bag of parenteral nutrition, you also put a filter on that. Now you filter the TPN, but if you're hanging the intralipids, the fat emulsion, you do not filter the fat emulsion. You want to watch for any signs of infection or septicemia. So any local manifestations such as redness, tenderness, drainage around the catheter site, or systemic signs of fever, chills, nausea, vomiting, malaise. So if they suspect a infection, they would do blood cultures. Sometimes they remove the catheter entirely and culture the catheter tip. They would do a chest x-ray, making sure there's not any changes in the pulmonary status, and really make sure that the dressing is changed daily until the site looks like it's healing. So catheter-related problems then can be air embolism, catheter-related sepsis, dislodgement, thrombosis of the vein, or phlebitis. There could be bleeding, occlusion, pneumothorax, hemothorax, and hydrothorax. Other complications, metabolic-wise, you could have an altered renal function. You could have a deficiency of essential fatty acids. You could have either hyperglycemia or hypoglycemia, liver dysfunction, or refeeding syndrome. This would include fluid retention and electrolyte imbalances, and hypophosphatemia is the hallmark of refeeding syndrome. So a low phosphatemia. Patients are going to be predisposed if they have long-standing nutritional states.